I know it's the last session of the day, so we're going to make this the most exciting session of the whole day. I want to begin, I'm going to talk about screening for pancreas cancer, which most of you probably haven't thought too much about. But if I can take you back a little bit, some of you are a little bit younger than I am, but if I take you back to about 1995, when I was a GI fellow, nobody wanted to go into gastroenterology. The major programs, at least in the United States, even the Harvard programs, weren't filling, which is probably why I got in. The reason for that is gastroenterologists didn't do very much. We took care of people with belching and gas and stomach pain, but we didn't start doing screening colonoscopy until about 1996. And that's when the US government approved payment for screening colonoscopy. In the span of about 10 years to 15 years, for people who get high quality colonoscopy screening, we've dropped the risk of colorectal cancer and death from colorectal cancer by more than 50%. I think we're at that point in pancreas cancer where we are now, where we were in colorectal cancer back when I started my GI training. We now have the technology to detect patients who are at risk for pancreatic cancer, enroll them in an active screening program, and I'll show you evidence today that patients who are in active screening programs have a dramatically better overall survival from what is otherwise a nearly uniformly fatal disease. So let me get into my talk now, and hopefully that gets you a little bit excited about the future of screening for pancreatic cancer, which I think starts today. These are my disclosures. This is the background that we all know about. Pancreas cancer is almost uniformly fatal. We've had a success in the last 5 years going from an 8% overall 5-year survival to a 12% overall survival. And we call that a success. That's not a success. That's a little tiny incremental improvement, but we haven't yet solved the fundamental problem that pancreatic cancer mostly presents at late stages, and even at the localized and regional stage is fatal in almost 50% of cases. So how can we change that algorithm? Well, we know from other cancers, and almost all the cancer success stories, whether it's colon cancer, breast cancer, cervical cancer, prostate cancer, the reason for those successes, and forgive the oncologist in the room, is not because we got miraculous chemotherapy, maybe with the difference with immunotherapy, but it's because we had effective screening programs, and we shifted the stage of detection from 3s and 4s to 1s and 2s, or even intraepithelial neoplasia. To do that in pancreas cancer, as in other cancers, we have to be able to detect and characterize early lesions, pancreatic intraepithelial neoplasms and cystic neoplasms. We need a reasonable window of opportunity between detection and when the disease becomes fatal. We have that certainly with pancreatic cystic neoplasms, and I'll show you data that we have it potentially with solid neoplasms as well. We need to distinguish high risk and low risk. We can't do pancreatectomies on every patient with a cystic lesion because the vast majority never develop pancreas cancer, and more people will die from the surgery than would die from the pancreatic cancer. We need a prevalence that's sufficient enough to screen, and this is different than colon cancer, which is very common throughout the world. That's why we screen the general population. Pancreas cancer is much less common, so we need to enrich the population to identify those who are at increased risk and screen those individuals. But we're not at a point where we are debating screening every individual. And finally, we need evidence that screening saves lives, although we're just reaching that point with colorectal cancer, which we've been doing for 30 years now. The paradigm for effective cancer screening is the so-called define, enrich, and find. So define means to find people who are at risk for the disease, further enrich that population to those that are at highest risk for the disease, and then find the disease. In pancreatic cancer, we need to do that first through non-invasive low-cost test, a blood test, a stool test, just taking a family history that your relatives had pancreatic cancer. These need to be high sensitivity, but not necessarily high specificity. We need to then further enrich the population with minimally invasive tests, such as endoscopic ultrasound and MRI. And then ultimately, we need to prove and localize the cancer. This is relatively easy. We have endoscopic ultrasound, fine needle aspiration, and biopsy. This has to be very highly specific, which it is. So really our focus is on the first two steps. How do we define the at-risk population, and how do we enrich that to find a group that benefits from screening? The model for this is a group at Johns Hopkins University led by Dr. Marcia Canto called the International Consensus Guidelines on Cancer of the Pancreas Screening, or CAPS. And you'll hear the term CAPS guidelines. Basically, the goal is to detect T1N0 disease, or high-grade dysplasia, also called high-grade intraepithelial neoplasia, and then screen those high-risk individuals. High risk in this study is defined as 2 or more first-degree relatives, or 3 any relatives, or a known genetic mutation, such as a Peutz-Jeghers, Lynch syndrome, BRCA1, or FAM, or a cystic neoplasm, IPMN, or an MCN. And the method of screening in this trial, which has been going on for more than 10 years now, is annual imaging, typically alternating between MRI and endoscopic ultrasound. Is this cost-effective, and is the yield relatively high? It actually is. So we go using these methods. The yield for finding a case is about 1 in 100. That may seem a little bit low to you, but that's a threshold value for when screening becomes cost-effective. And this is a study that we published looking at the cost-effectiveness of screening these types of individuals: family history, known genetic mutation, or cystic neoplasm. And in fact, it's highly cost-effective. In fact, it's cost savings. If you look at the screening individuals from the age of 44 up to about 70, it's actually cost savings to screen individuals who are at that 1 in 100 or higher risk of developing pancreatic cancer in their life. So it looks like, in theory, this should be helpful. And I'll show you data that in practice it actually is helpful. So this is the CAPS study outcomes. This is now 10 years into the study. And they looked at overall survival based on whether they were detected in screening. And these included cystic lesions, IPMNs, and high-grade intraepithelial neoplasia in yellow, which were almost all cured. Pancreatic cancers detected during surveillance in blue, and pancreatic cancers that were detected outside of the screening program in light blue on the left. And you can see this dramatic shift, and they've actually adjusted this for the important things like lead time and length time bias. So that's very important. We now have good evidence. It's not a randomized trial, but it's good evidence that screening using these definitions significantly works. We now have a second trial from the other large international group that enrolls patients in a screening program. This is the Dutch pancreatic screening cohort. They have a very large population of families who have the CDKN2A or FAM mutation. These patients all undergo annual imaging, again, MRI alternating with endoscopic ultrasound. And you can see similar survival curves in the lower right-hand corner, where individuals who were screen-detected cancers had much better overall survival than individuals who were detected outside of the screening program. So now we have 2 large international cohorts that says that screening is likely effective. And again, both of these were controlled for length and lead time bias. That's what we have today. And we can use the tools we have today to effectively screen. What about what's in the pipeline? Fortunately, we have lots of good potential tests that are in the near-term pipeline, meaning things that are either available within the next few months or within the next year. First of all, pancreatic juice biomarkers. I'll show you the data from our group. This is a test that will be commercialized likely by next year and can be collected through a normal endoscope or at the time of an EUS. It does not require cannulation of the papilla. You just give secretin and you collect the pancreatic juice and you run a number of tests on it, which I'll show you in a moment. We also now have the multi-analyte blood test. You saw a couple of months ago, the US Food and Drug Administration approved the first DNA-based circulating cell-free DNA test for colon cancer screening. The same group that got the FDA approval for colon cancer, they have almost all other common human cancers already in the pipeline. So pancreas cancer, liver cancer, esophageal cancer, ovarian cancer, breast cancer. The same panel of markers although not FDA approved, are now being widely used in the general population. We actually have just recently opened a clinic called the MCED Clinic, the Multi-Cancer Early Detection Test Clinic, because so many patients are coming to us having done this test, and they say, I've got cancer somewhere, I want to be screened. We also have multiple AI-related tools, which I'll touch on, and also so-called large language ambient systems to monitor our medical record to see when red flags appear that maybe we're not paying attention to, but a large language model can be run in the background of our electronic health records and flag these patients. This is the pancreatic juice test. It's collected very simply through an endoscope. We give secretin. We collect about 5 cc's of pancreatic juice from the duodenum. It does not require cannulation. This is the data. Dr. Shaunak Majumdar has been the major leader on this study. The accuracy of these 3 biomarkers, these are methylation-based, so it's altered methylation of the DNA. The team that developed this is actually the same team that developed the Cologuard test, which is the methylated DNA in stool, and has now been commercialized for over 5 years. This test has a very high degree of accuracy, and it's independent of stage. You can see on the right side, it detected stage 1 and 2 at the same overall accuracy as stage 3 and 4. So we anticipate that this will be added to those patients that are getting their annual endoscopic ultrasounds. We'll collect some pancreatic juice, we'll run this test on it, and further enrich our population. And again, this has now been through about 10 years of study. It's been submitted through the equivalent of the FDA process for diagnostic test called CLIA certification, and we're anticipating that certification and commercialization within the next 12 months. The other thing that we can all pay attention to is new onset diabetes after the age of 60. We're all familiar with the patient who's gaining weight and gets diabetes. That's type 2 diabetes. But you may be less familiar with the patient who's losing weight and gets diabetes. That's type 3 diabetes or pancreaticogenic. And it's due to alteration in our metabolism that causes a ketogenic effect. We lose body mass, particularly fatty body mass, and yet our sugar is rising. This was a study done by my colleague, Dr. Suresh Chari. It's a classic study now that took a large cohort of individuals diagnosed with pancreatic cancer and looked backwards in time, 5 years before, 3 years before, 1 year before, and showed that the sugar starts to rise, and this is the graph. So on the far right-hand side of this graph is the diagnosis of pancreatic cancer. Going left is the change in their blood sugar in the 1, 3, and 5 years prior. And what you can see from this graph is that about 3 years prior to a clinical diagnosis of pancreatic cancer, their blood sugar is statistically rising compared to their baseline. Now, this is not something that we do in our normal practice. You don't pay attention to slight rises in sugar and a slight fall in your weight. But this is a perfect scenario for the so-called ambient or large language models, where now we can run this on every patient that comes to our clinic every single day and create a flag that says this patient is a kilogram less than they were a year ago, and their blood sugar is 5 milligrams per deciliter higher than they were a year ago, and they're 63 years old. You should pay attention to this patient and maybe image their pancreas.
So we have 2 minutes.
Okay. Other recent changes that we've just published are changes in body fat along with the glucose. So we've added changes in visceral fat, actually dropping in cholesterol, which is also decreasing 3 to 5 years before a clinical diagnosis. I'm going to quickly touch on AI and MRI imaging. So this is a study from our group showing that an AI algorithm is as accurate as our best radiologist. It's saying this cyst is high risk, it's cancer or high-grade dysplasia, or it's low risk, it's low-grade dysplasia or non-neoplastic. So we can now run this algorithm in every MRI that we do, not just the one read by our best radiologist, but the one read by our average radiologist, or even the MRI done for the kidneys or the MRI done for the liver, where they're not necessarily looking at the pancreas. This is another study, very interesting, from our colleagues at Mayo Rochester. Took patients diagnosed with pancreatic cancer who happened to have had a CT scan for some other reason 3 years before. Was not detected on the clinical read at that time, but developed an AI algorithm that can now detect almost all of these cases, even when the radiologist doesn't see it. So what we're starting to do now is run these ambient algorithms in the emergency department of every patient that gets a CAT scan for any reason and flag the ones that don't have an obvious tumor, but by this algorithm are predicted to develop a tumor within 3 years. So now we have this new algorithm. We have shifted our ability to detect cancer about 3 years back in time through new onset diabetes, circulating biomarkers, changes in muscle fat, and now we have the ability to shift that curve from stage 3 and 4 disease to stage 1 and 2. So our new define enrich algorithm is now use a combination of non-invasive blood and stool test, ambient imaging. Everybody's getting a CAT scan for every abdominal pain or kidney stone that they have. Let's use our AI algorithms to flag the ones that might have pancreas problems. Then enrich it using defined AI algorithms on their MRI and endoscopic ultrasound. We developed them for MRIs. They work very well. We're working on endoscopic ultrasounds. We're not there yet. And then finally find that. Again, that's the relatively easy part because we have good biopsy. So to summarize, we're really at the cusp of a new era in screening for this otherwise deadly disease. Screening of pancreatic cancer in high-risk individuals is cost-effective and identifies early-stage disease, which is associated with improved survival. The current system, asking about family history, genetic testing, new onset diabetes, are underutilized. AI is rapidly transforming our ability to run ambient algorithms on the electronic health record, including imaging, and preliminary work on pancreas cancer detection looks quite promising. Fourth, we need automated workflows to passively monitor for clinical evidence such as new onset diabetes when we're not necessarily looking at it. These are not gastroenterologists or pancreatologists who are looking at that CT in the emergency department. It's being looked at passively by an AI algorithm. And lastly, the AI and machine learning radiomics detection and classification is likely to surpass current standard of care radiology. Thank you very much.
So we're going to go through the program quickly.